Alrighty, welcome everybody. Thank you for being here. Today we are going to be talking a little bit about the role of myofunctional therapy in the dental field. There are so many pieces to this puzzle that I'm going to try to make it in 2 hours. But anyways, if you guys have any questions, let me know. Screenshots are welcome. There is our QR code for our Instagram. If you guys can get your phones out and scan the QR code, you are welcome to share any of the screenshots from today's presentation. Just make sure you tag us. I like to start every presentation with this famous quote by Aristotle. He says, the more you know, the more you realize you don't know. And that's why presentations like this and meetings like this, actually, congratulations doing putting this together, are so important because we get to learn from different healthcare professionals or different specialties because every single one of our colleagues hold a piece of the puzzle. I found this chart the other day and I thought that it fit right in with what we do. It's called the Rumsfeldian knowledge. So if you look at the green circle, that green circle keeps growing based on your experience. The yellow is, let's say, your dental hygiene training. The orange are things that you know that you don't know. You're aware of them, but you don't know much about it. Let's say dental sleep medicine or how to do a filling. You know about them, but you don't necessarily perform them, right? And then the red circles are infinite. And those are unknowns that we don't even realize that are out there. Those can become orange and then eventually yellow if you take the time to learn new things. So your dental hygiene training is the yellow right there. And myofunctional therapy, let's say, if nobody has heard of myofunctional therapy, you're in the red, but it's going to become orange today. So this is my story. As a young child, I suffered from indoor allergies. I used to walk around with a tennis shoe box with tissues inside because I needed to blow my nose constantly. I am not sure exactly when it started, but I became a mouth breather. I had difficulty concentrating in school. I had a harder time learning new material. I was a B and a C student, even though I tried so hard. As a teenager, I was an ugly duckling. I remember watching a school performance, and my posture was absolutely awful. It was so embarrassing. My mom tried. She took us to get x-rays done. I remember I found out I had scoliosis, kyphosis, and lordosis, all three spinal issues. They recommended a brace to hold my shoulders back, but no one actually addressed the root cause. I could not breathe. I had to use 2 pillows at night, otherwise I couldn't sleep. My nose would shut off immediately the second I lay down. I was addicted to those nose sprays. It was the only way I could breathe at night for a little bit at least. Now, I'm so passionate about this, guys, because I don't want any other children to have to go through what I went through. And now I know that there's a way to help them feel better by breathing and sleeping better. How can I be quiet? How can I not share this with the world? My life would have been very different if I had the opportunity to have 18% more oxygen into my brain and my organs. Thankfully, I'm working on getting better now. You guys can tell I have a little bit of a lisp. I actually have a MARPE in the roof of my mouth right now. It's a mini implant assisted rapid palatal expander. There's 6 implants total on my palate, and it's cranking up the maxilla, cranking open the maxilla. So I have a bunch of spaces now in the front. But immediately, the second that this started expanding, because I was very narrow, I had no crooked teeth, I was just narrow. So when I started expanding, for every millimeter of opening in between your teeth in a maxillary suture, it is 4 millimeters of opening in your nasal cavity, because the roof of your mouth is the floor of your nose. The second you expand here, you can breathe better. And then if you can breathe better, you can sleep better. So let's see. We have to start from the beginning. In this field, we often hear how newborns are obligate nasal breathers. Infants are able to suck and swallow, suck and breathe, but they are unable to breathe and swallow at the same time. Their small mouth, short nose, large tongue, and low lung capacity makes breathing overall difficult. Anywhere from 6 to 18 months, the epiglottis descends. So this allows for the child to start making sounds. But this descent also increases the risk for airway collapsibility. It's around this time that the child can start snoring and develop sleep apnea. Breathing is not only about oxygen. Don't we believe out there, people say all the time that we need more oxygen or carbon dioxide is bad. It's normal to mouth breathe. Breathe in through the nose and out of your mouth. All of those are incorrect. And we'll learn why today. The air around us has enough oxygen to literally totally saturate our whole body. The idea that breathing more will give us more oxygen is just not true. Carbon dioxide is not just a waste gas. It actually plays a huge role in how much oxygen is released into our organs and muscles. We make our own CO2 through metabolism by breaking down carbs and sugars. The byproduct is water and CO2, which we need to store in our lungs. We don't have to make or store oxygen. So over time, dysfunctional breathing tells our brain that that's how we should breathe. So you'll notice some people holding their breath throughout the day or sighing all the time. It's our body's way of trying to find homeostasis, going back to what it knows always. Your nose is a filter, and it warms air before going into the lungs. It produces something very powerful called nitric oxide every time we exhale through the nose. It reduces the amount of pathogens going straight into the tonsils. It reduces allergies by having to swallow allergens after the nose filters it. It increases the CO2 storage that we were just talking about in your lungs, helping the hemoglobin release oxygen into your blood. It increases IQ, concentration, memory, energy, exercise endurance, due to more oxygen being released into your brain, muscles, or organs. What are some symptoms of breathing dysfunction? So this might blow your mind. Crooked teeth, that's one of the first ones. Dry mouth, periodontal disease, caries, snoring and sleep apnea, chronic nasal congestion, digestive disorders, nasal polyps, allergies or hay fever, asthma and other respiratory disorders, bedwetting, adenoid and tonsil enlargement, anxiety or panic disorders, fight and flight responses, bruxism and TMD, postural issues, hypertension, angina pectoris, epileptic seizures, chronic fatigue, and fibromyalgia all could be related to breathing dysfunction. So the nose is your body's natural filter. It has three main jobs. It filters the air, it warms the air, and it humidifies the air. You are supposed to breathe in through your nose and breathe out of your nose. Your lips should always be sealed, promoting nasal breathing, and your tongue should always be up. Your tongue is key in this whole process. By breathing through your nose, you will produce something called nitric oxide. Nitric oxide is antiviral, antibacterial, antifungal, anti-inflammatory. It's a vasodilator. Breathing correctly through your nose will also increase the amount of CO2 your body can handle, which dictate the amount of oxygen that is released from your hemoglobin. So whenever you breathe in and slowly out, the slower the exhale, the more nitric oxide is produced in your paranasal sinuses. So your lungs hold CO2, and you have a certain CO2 pressure, mercury pressure in your lungs. The one we're looking for is like 38 to 42. And a lot of people are not even close to that. Meaning, when you breathe in and out, all the CO2 is going in and out because you're breathing too shallow. Breathing fast in, fast out, fast in, fast out. If you start regulating your breathing, slow in and slower out, you start teaching your lungs how to hold on to more CO2. The more CO2 you hold, the more CO2 you have in there, higher the pressure, the more the hemoglobin is going to be able to release the oxygen that's already in your blood because you're breathing in enough oxygen. But it's going to be able to release that oxygen to go to the places that it needs. One of the things that I've noticed after expansion that it's blowing my mind, it's my skin. My skin looks so much healthier. I've always had issues keeping my skin clear. And after expansion, I'm serious, I'm not doing anything different. My skin looks so good, but why? Because I have so much more oxygen going to my skin. Whenever you have a really good night of sleep, you sleep really, really good, you wake up in the morning, you look better, you feel like your skin is refreshed. That's what's happening, which is pretty cool. These are actually my ants. In order for your facial structure to grow adequately, a few things need to be in place. The first one is nasal breathing. Your tongue grows based on genetics, but the bone structure grows based on your breathing and the function of your orofacial muscles. What else promotes orofacial growth? Breastfeeding. The longer a baby breastfeeds, the better. If you guys have ever seen a baby breastfeed, it takes so much work and so much energy. They really have to exercise those muscles of the cheeks, the lips, and the tongue to be able to get all of the milk out. Whenever a baby drinks from a bottle, they don't have to try hard or as hard. So what happens? Those babies that are breastfeeding, and we know that, we're all working moms, it's almost impossible to exclusively breastfeed nowadays. But you notice that whenever a baby is breastfeeding, they're going to the gym every day. In order for the bone structure to be strong and to grow, you need to exercise the muscle. What happens if we only use one arm constantly over and over and over? This arm is just going to be so much stronger. The bone structure is going to be better on the side, and this is going to be weaker. It's the same thing with our orofacial muscles. But breastfeeding, the mechanism of breastfeeding is also important to get your muscles strong enough in order for you to start eating food. So chewing hard foods is very important for orofacial growth. Back in the day when my aunts were little, they were being given chicken bones and stuff to gnaw on. Nobody blended their food. I was so proud when I had my first child that I bought a baby blender and I made all homemade food for my daughter. Well, she didn't have to chew at all. And nowadays we have baby food and we have pouches and we have mac and cheese and peanut butter and jelly sandwiches. Nobody needs teeth to eat that. Before, they really had to chew. And that chewing is just, you start with breastfeeding and then you go into chewing hard foods. It's the levels of strengthening the whole orofacial muscle complex. Your tongue suction to your palate. The pressure of your tongue on the roof of the mouth is going to help the whole structure grow. It actually stabilizes the whole structure. If you think about your head as a building, and let's say that your tongue is the foundation of that building. If the foundation is down, the building collapses. Your skeletal structure, we have sutures all over the bones of our head. And those sutures are malleable. If there's nothing holding up to hold that whole structure together, things will move a lot more and not grow to its full potential. Excuse me. And of course, having a nutritious diet. It's insane right now. Gut health, it's a huge topic. I'm going to go a little bit into it, but of course, we don't have as many nutrients as we used to, and it is affecting our growth too. So there's the breastfeeding that I just talked about. It helps develop the orofacial structures, suction, breathe, and swallow. It is a muscle exercise and it promotes nasal breathing. They have to breathe through their nose. Chewing, and a lot of these are my kids. That's my little boy. Hard foods versus soft foods. Pressure builds bone. It strengthens the muscles, and it also initiates digestion. So after World War II, Gerber came out with baby food. But why? There was a huge shift back in the day when industrialization happened, because moms all of a sudden had to go to work now because the husbands weren't home anymore. When the moms had to go to work, that's when Gerber came out, because moms could no longer breastfeed that long anymore, and the kids needed some more nutrients. You guys still might hear some pediatricians recommend baby food at 4 months. This is where it came from. It was during World War II that they started recommending Gerber for 4-month-old babies, because they didn't have their moms around them anymore and they just needed something. Make sure I didn't miss anything over here. A good example of the muscle function in relationship to the bone strength and growth is Stephen Hawking. Do you guys remember him? He had ALS. ALS causes loss of muscle control. It does not affect the bone. However, over the years, the bone got deformed. If you see him, he was perfectly normal, and all of a sudden he started getting totally deformed. It's because the muscle stopped working. It causes muscle atrophy. And chewing also initiates digestion. You get your body ready to receive the food and break it down. If patients are not doing enough or properly chewing, digestive problems can occur. I have lots of patients that come to me with constipation, and in probably like 9 weeks of myofunctional therapy, usually is what it takes, it goes away completely. And they just went to the pediatrician, and pediatrician recommended Miralax for the rest of their lives. And we all know that Miralax should not be taken long term, and it should not be given to kids. So that is me before expansion. Your tongue is the frame and foundation of your orofacial-skeletal structure. Your tongue's function is, one, to protect your airway. And you guys can try this with me. You can suction your, first actually open your mouth and take a deep breath in through your mouth. Now, I want you guys to suction your tongue to the roof of your mouth, like in the picture. Swallow, suction, and now with your suction open, try to take another breath in through your mouth. You can't. So that is the significance of having the tongue in the right position. You cannot breathe through your mouth. So tongue position, to me, is more important than working so much on nasal breathing, because if your tongue is up, you can't breathe through your mouth at all. You have to breathe through your nose. Your tongue position at rest also will initiate your swallowing and your speech. So if there's any issues with speech and swallowing, we have to look at tongue position at rest. Your tongue supports and widens the maxilla. The pressure of the tongue in the maxilla, if it stays up there day and night, is going to help widen. And you guys can tell in this photo, I was super narrow. I have no crowding, so nobody would ever tell me I needed braces. All right, and that's something that you guys are going to start looking at a little bit differently now. It's not about having straight teeth and a beautiful smile. It's about everything functioning properly, how it's supposed to. And I also had a tongue tie there. I had my tongue tie released. And the tongue also helps maintain occlusion. How many times have you had somebody that had braces more than once? A lot of times the culprit is mouth breathing and the tongue position. Tongue pushing on the incorrect structures will and can move teeth at rest, not during swallow, but at rest. So this is Dr. Weston Price. He was a dentist known primarily for his theories on the relationship between nutrition, dental health, and physical health. He was a founder of the National Dental Association and research section of the American Dental Association. He's most well known for his 1939 book, Nutrition and Physical Degeneration, detailing his global travel, looking at the diet and nutrition of various cultures. This information, I got it from landbyland.org. So Dr. Price traveled to many different indigenous communities in the world. He compared their teeth to those who have also been introduced to flour and sugar or industrialized food. The differences were shocking. The communities who had not been introduced to refined foods had 20 times less cavities, less birth defects, less susceptibility. I can't say that word. Somebody help me. Susceptibility. Thank you. To infection. This Marpy is really messing my speech up. More physical strength. How crazy is that? Which goes into the low muscle tone. Less irritability and less violent behavior. He also said children who were eating healthy and whole foods were more good looking because they were developing better facial bone structure. The Dental Diet is one of my favorite books. It's one of the first books I ever read when I started studying airways by Dr. Stephen Lin. He is from Australia. If you don't follow him, please do. He's wonderful. But he talks a lot about vitamin A, D3, and K2. For all of those patients out there that have tons of tartar, tons of calculus that come to you over and over, and you're like, oh my gosh. We all learn in hygiene that those patients have a higher risk to also have stroke and heart attack because they have a higher risk of having plaque in their arteries. And it's because of deficiency in vitamin K2. Vitamin K1 is green leafy vegetables. Vitamin K2, and it helps with bleeding. Vitamin K2 comes from fermented foods. So kimchi, sauerkraut, kombucha, that type of stuff. And K2 tells calcium where to go. So if you don't have K2, you're more likely to get calculus on your teeth. You're more likely to get a plaque in your arteries. You're more likely to have those things. I've had patients in the past who had to come see me every 3 months for cleanings just because of the amount of buildup. And after they started supplementing with K2, every 6 months was plenty. So take that into consideration. It's kind of crazy, the things that we learn. These are my friends, Dr. Kevin Boyd and Dr. Mariana Evans. They are two of the most important dentists in this airway field because without them, we would not have all of this research and proof that prior to the industrial revolution in Europe and North America, there was no evidence of malocclusion. I mean, stop for a second. Why, right? They're looking and measuring all of these prehistoric skulls to find out what are the dental differences prior to the Industrial Revolution and after. Mariana Evans is an orthodontist, periodontist from the University of Pennsylvania School of Dental Medicine, and Kevin Boyd is a pediatric dentist and dental medicine consultant at Lurie Children's Hospital in Chicago. And he also does a consulting visiting scholars at the University of Pennsylvania's Museum of Anthropology and Archaeology. That's where they did all this research, was there. They opened the vault to them and they were able to see all these prehistoric skulls. One of the things they noticed was the anterior posterior dimensions of the mandible and the maxilla was most affected post-industrialization. So not only the transverse, we call this transverse deficient. So if somebody is narrow, they're transverse deficient. If you see those people that have their jaws like this, we call that AP, anterior posterior deficiency. Those are a lot of the people that are going to have sleep apnea. They're going to need double jaw surgery. And there they are. And this is not new. George Catlin wrote this book in the 1800s after spending 10 years traveling and living with native tribes in North and South America. he found out that mothers would hold their baby's lips closed for a little bit after the baby's finished nursing. In the book, he states there's no other animal in nature that sleeps with their mouth open. If you saw a horse with his mouth open, what would you immediately think? Right? That they're sick. But we have come to accept the fact that mouth breathing is normal because it's common. And that couldn't be further from the truth. And those are somebody in my family also, great uncles, I think. But see, the little girls in the photo, my aunts, both had their lips closed, breathing through their nose. And these kids already, which are their kids probably, their children, had their, actually, I don't know. I think they came after them. But they had their lips open. That's not good. And immediately you're seeing facial changes happen. The study by Dr. Gelb, this is a great study by Dr. Gelb. It highlights the importance of growth and development. It says that children with narrowed airways in either obstruction are often or have often undiagnosed UARS or OSA, obstructive sleep apnea. How many patients do we see that have a gummy smile? I have one. A bump in the nose. I have one. Have a long face. I check all the boxes. Those changes are being caused by a low tongue position, lack of chewing, and mouth breathing. The article continues to say that crowding and crooked teeth are a symptom or a compensation of an airway problem with an underdeveloped mouth and epigenetic changes secondary to breathing issues during the day and night. But the takeaway from this is that nasal breathing can reverse this trend during early development and needs to be promoted through a multidisciplinary approach. So pretty much if we see kids that are 2 years old and they have no spaces in between their teeth, we already know they need braces, right? But we're not referring them until 12 because these orthodontists are not going to see them until they have all permanent teeth. It's insane. And then they send them back to us, extract 4 teeth. What happens when they extract 4 teeth? They have to push everything back. All of a sudden, they just made that person AP deficient. So those are 40, 50, 60-year-old adults who have a very flat face, who are now having TMJ issues, who are now having sleep issues, who are exhausted during the day. You know, a lot of women have UARS. I'll talk a little bit about UARS. But it's crazy. They're not following these people. They're making their teeth fit their cavity, their oral cavity, but they're not making the oral cavity big enough to make sure that their teeth can go in there. We should be doing the opposite. So let's start treating these kids early. I mean, if nasal breathing has this huge impact, let's teach these kids how to breathe through their nose. That's what my functional therapists do. And we can get them early. And we can go ahead and start promoting chewing. And we can start exercising these muscles so it promotes bone growth. It's crazy whenever you see the changes in these kids with few sessions. Excuse me. This study looked at an animal. Oops. It was the hyrax. And they found that those eating cooked food reduced about 10% of the size of their faces, supporting what we say about humans. Isn't that crazy? If they had to chew hard foods, their faces were larger. So this is interesting. Breathing is one of the most vital functions of the human body and provides with the oxygen that we need to survive. But despite this, most of us don't think about how we breathe. This is a quote by Patrick McEwen, a good friend of ours, that teaches Buteyko breathing. And I talked about already what nasal breathing increases IQ and all of that stuff. This is a photo by the Breathe Institute. And it's interesting to me because when I look at a mouth breather, that's how I've always looked like growing up. Open mouth posture, bump on my nose. It kind of looks like me. Forward head posture. Why do these people have forward head posture? Does anybody know? Everybody can try here. Put your shoulders way back, your head way back, your ears on top of your shoulders, and take a breath in. Way back there. Now we're going to go here. Forward head posture, shoulders rolled forward, take another breath in. So much easier. That's why, because we can't breathe. You address breathing, and a lot of times we can bring everything back. Also, our head weighs about 12 pounds. If I hold a bowling ball right here, my arms can handle a little bit. But if I hold it right here, I'm not going to be able to hold that long. So what's happening to the muscles that are holding our head? So those people are going to have tons of neck aches and headaches because of the forward head posture. So it is a snowball effect. And now that I'm getting expansion, I mean, I'm still a little bit far off, a little bit farther off from the nose breather, but my facial structure is completely changing. I'm starting to look a little bit more like the nose breather picture, which is crazy. So mouth breathing versus nasal breathing. Mouth breathing has a negative effect on the craniofacial development of these children. They are more likely to have increased overjet. So if you guys are seeing this in the dental offices, increased overjet, a high vaulted palate, posterior cross bites, and lip incompetence. If somebody walks in and their lips are not touching, check mark. They open their mouth and they have a high vaulted palate, check. They have an overjet. What do? Orthodontists will extract two premolars and push the maxilla back. It's the mandible that's too far back. And then they just pushed now the upper jaw back too, so everything's too far back now. And to correct that, it's crazy. It takes it's usually surgery. If you guys want to take a screenshot of this, these are some books that I have read that I recommend for those wanting to learn more about this field. The first three are by Patrick McKeown, from the quote right there that I read earlier. And the last one is by James Nestor. James Nestor was just in my favorite podcast, The Diary of a CEO. I've met James Nestor, and Patrick is a friend of mine. But The Breathing Cure is a huge book. I would start with the Close Your Mouth. It's very small and easy to read. The Oxygen Advantage was the first book I ever read that got me into this field, and my mind just went. I was like, oh my gosh, there's so much that we can do for our patients, so much more that we can do for our patients. And then breath just puts all the pieces together. And The Breathing Cure is more advanced. Any questions so far? Anybody want to say anything? I can't see the chat, so you let me know, Ashley.
Nothing currently in the chat.
Okay. If I'm going too fast, you guys let me know. I don't know if I'm going to be able to make it. We are able to breathe through our mouth. Everybody's allowed and able to breathe through their mouth, but it's a survival mechanism. But chronic mouth breathing is detrimental to our health. Our nose has a function, and our mouth has a function, or many functions for that matter, right? But breathing is not one of them. So if you're bypassing your body's natural filter, it's going to dry out your nasal passages because you're not getting all the moisture through the air that you're supposed to. That in turn causes inflammation, and it makes it more difficult to breathe through your nose. So the more you mouth breathe, the more you have to mouth breathe. And it decreases the CO2 retention and the oxygen release. And there's no nitric oxide production. You are healing when you're breathing through your nose and breaking down when you're breathing through your mouth. So mouth breathing is not dysfunctional. Mouth breathing is only dysfunctional when you are mouth breathing in place whenever you should be nose breathing. So if you're sitting there right now at rest, you're not running, you're not working out, your sympathetic system shouldn't be on. Its parasympathetic system is rest and digest. So doing rest, sitting down reading a book, you're sleeping, watching TV, you should always be breathing through your nose. So if you see people breathing through their mouth in those instances, that's when it's a red flag. The way you breathe will affect your craniofacial development. On the first photo, you see a boy with his lips closed, beautiful jawline, breathing through his nose. What happened? He got a gerbil for his birthday. And the gerbil stayed in his room, and he was allergic to it. Then he started mouth breathing, and you can see that just in a short period of time, his face completely changed. Increased the white underneath the eyes, everted lips, his lips turned out, a big nose, looks like his mandible is all way far back now, just because his tongue is low and he's putting weight on his jaw. All of a sudden, isn't that insane? This is by Professor Mew. He's from the UK. He's huge in this field. If you guys have heard of mewing, that's who started mewing. This study right here, this is a crazy study. So they plugged the nasal passages of these monkeys, forcing these monkeys to breathe through their mouth. All the mouth-breathing monkeys gradually changed their facial appearance and their dental occlusion from those who were breathing through their nose. Of course, they don't allow us to do these types of studies anymore. But then after they took the tape from their nose, they were able to breathe through their nose again and slowly started getting better. So we can reverse these things if it's early enough. These guys over here won the Nobel Prize for nitric oxide. I already talked a little bit about this. Nitric oxide is produced in the paranasal sinuses, but it's only produced when you breathe in through your nose and out of your nose. Nitric oxide acts as an antiviral, antibacterial, antifungal, anti-inflammatory, and it's also a vasodilator. It also plays a role in your body's homeostasis, platelet function, and mitochondrial function. Needless to say, it's a very important molecule. It also has effects on neurotransmission modulation of the hair cycle and penile erections. Nitroglycerin and amyl nitrite serve as vasodilators because they are converted to nitric oxide in the body, popularly known by the trade name Viagra. So a lot of these older men with sleep apnea will have erectile dysfunction because of lack of nitric oxide. So if we can teach them, they just need to breathe through their nose. Oh, that's always a good sales pitch. There was some research done during the previous SARS-CoV epidemic. This is Rosalba Courtney. She's also from Australia. If anybody wants to learn anything about breathing, she is the one you should go to. And it showed the nitric oxide inhibited the replication of the virus. So many places this time around during the recent COVID-19 used actually nitric oxide to treat COVID. But as we mentioned earlier, nitric oxide produced in your paranasal sinuses. And there are a couple of ways to increase the production of nitric oxide. One is through humming, as you can see in this graph. Humming is able to increase nitric oxide levels 15-fold as compared to normal quiet breathing. A case study of a patient who had been able to nose breathe due to chronic sinusitis for a month. He had been unable to breathe through his nose because of chronic sinusitis, was able to achieve a clear nose and breathe easily through his nose after 4 days of intensive humming. He did 1 hour the first day and 120 hums 4 times per day. The authors hypothesized that the effect was due to the increase in nitric oxide produced by the humming. There are also some breath hold techniques that will increase the production of nitric oxide. Many myofunctional therapists work with both of these techniques. Nasal breathing also improves pulmonary function by improving the motility of the cilia. It also improves the circulation in the lungs so that the blood is better oxygenated by around 10%. This is Benny again. So nasal hygiene is one of the main things that we recommend. We need to clean our nose. And how do we do that? I don't think there's sound. Let's see. I don't think there's sound. But I recommend getting it, if it's a small child, getting a towel, putting a towel around so they can't lift their arms up. And of course, you're gonna make sure everything is super clean, so you don't get the brain-eating amoeba. So I have a water bottle, and I warm the outside a little bit, but everything is sterilized pretty much, or brand new open. And I put some saline packets in there, and wrap the towel around, and very fast hold his head so he doesn't move his head, and he comes all out. As a mother, there's nothing worse that, laying next to your child while they're asleep and they can't breathe. Oh my gosh, it makes you go, you know what I mean? And I have had times that they couldn't breathe, and I would wake them up, take them to the bathroom, clean their nose, and take them back to bed. I don't recommend doing that, usually I say 2 hours before they go to sleep, but in the middle of the night when they're sick, I'll do that a couple extra times, and oh my gosh, they could sleep so much better. Now I want to test everybody. Does everybody have some water with them? I would like for you to take a little sip of water, hold it in your mouth, and okay, ready? I'm gonna do a minute. 1, 2, 3, and go. Hold water in your mouth. You gotta do it. I want to know if you feel the urge to swallow. You actually gotta look at yourself in the mirror right now, and I want you to pay attention to a couple things. I want to know what second did it make you swallow if you had to. I want you to look at your chin to see if there's any contraction of this muscle. I want to know if your lips are pursing. I want to know if your breathing rate changed. A lot of times people all of a sudden start breathing heavier or have more audible breathing. Some people can't hold a head, a little girl hyperventilating 10 seconds doing this. If you guys pass the 1-minute breathing test, that means that you're comfortable nasal breathing. It should not be mouth breathing unless you're running from a bear. Let us know in the chat if anybody had a hard time. I'd love to know. Did everybody complete it? In the dental chair, there's actually a better thing that you can do with your patients. And you guys can try this now. You take a little sip, you bite down, and you swallow, showing me your teeth the whole time. Very good. So now this is what it looks like. Your lips don't move. Your tongue doesn't come forward. All you see is just right here. Your pharynx going up and down when you're swallowing. If you can't do that, that's a neurofacial dysfunction. Yes, every patient, good job. Made it, everybody. You guys let me know. I love this quote by Gary Brecka. He said that the presence of oxygen is the absence of disease. And now you guys all know how you get more oxygen. So let's start nasal breathing in and out of the nose and letting everybody know. What else can we do to help kids breathe better? So we reduce allergens, street allergies. I talk about the 3 Ds, dander, dust, and dairy. Dairy is inflammatory, swells up your turbinates, making it a little bit harder for you to breathe. Reducing dander, so no pets in the room. Reducing dust, so hypoallergenic sheets in your bedroom. Get rid of too many stuffed animals, too many pillows. Get rid of carpets, rugs, heavy curtains, anything that could be collecting a lot of dust. Get everything out of your room. It makes a huge difference when you're breathing at nighttime. Toxins, what are you using to clean your house? Is there mold in your house? Have you been exposed to mold? Cleaning supplies, laundry detergent, plug-ins, all of those things are going to affect your breathing. Perfume, lotion, all those fragrances. We also recommend an ENT evaluation for nasal obstruction or to check if they have enlarged tonsils, adenoids, or turbinates. And then orofacial myofunctional therapy, so we can work on the whole orofacial complex. Do you guys want to take a quick 5-minute break, or do I keep going?
I'm good.
Okay, I have 89 slides. I don't know if I'm on 33. Let's talk a little bit about sleep. So why does sleep matter? Why do we sleep? We sleep about a third of our lives. I like to say that throughout the day, our body breaks down, and at night, it heals itself. Sleep is responsible for hormone secretion, memory consolidation, and even body temperature regulations. It's necessary to repair the body from daily damage, growth, people that are not sleeping while they're not getting the growth hormone, energy, protection, memory, body temperature regulation, all of those. This amount of hours equals quality of sleep. So not always. I hear this all the time. But my child sleeps 10 to 12 hours. They're fine. Well, are they showing any symptoms during the day that could indicate they're not well rested? Some people actually need more hours than others. How many hours do you think you guys need? You can kind of tell. For so many years, I slept 5 hours, or from 2 to 5 hours. So a lot of times now I sleep 5 and I wake up and like my body just wakes up. I'm ready to go. But you should be getting more than that. How many hours do you guys think that you need? How about naps? Do you guys take naps? Let me know in the chat. And kids versus adults is different. 25% of the population is at risk for sleep disordered breathing. What is sleep disordered breathing? A general term for breathing difficulties during sleep that involves a disruption in respiratory and airflow patterns. It can be particularly detrimental to children's physical, psychosocial, and mental health and overall well-being. Sleep disorder breathing includes both obstructive sleep apnea as well as upper airway resistance syndrome. It's believed that about 66 million Americans are at risk. Data shows that only 15% of those are actually diagnosed and 10% are being treated. So how can we fix this? By having dentists start screening their patients. Dental hygienists see their healthy patients at least twice a year. Patients don't go to the doctor unless they're sick. They don't go to a speech pathologist unless they have a speech issue. But they come to us. We spend time with our patients. We get to know them, their diet, their activities, and they trust us. Have you ever had a patient fall asleep in your chair? Raise hands. I was so proud. I was like, oh my gosh, my cleaning was so good. He couldn't even, he fell asleep. That's a symptom of sleep apnea, especially if it's a common occurrence for that patient. So the ADA is now recommending, they started this policy in October of 2017. And they started, or the policy was stating that dentists are the only healthcare providers with the expertise to provide oral appliance therapy, which is a treatment for sleep disorders. The key components include assessing a patient's risk for sleep disorder breathing as part of our medical and dental history, and to refer those patients at risk to the right provider. There are about 163,000 dentists in the United States. There are about 8,000 sleep physicians, with only 4,000 of those practicing. Actually, 133 of those are pediatric sleep physicians. There's just not enough people to screen and diagnose these patients. They need our help. But how do you screen? It's easy. I'll show you guys. We all know that poor sleep can cause fatigue, but did you know that poor sleep is connected to all of these consequences? Undiagnosed sleep apnea costs the United States over $150 billion a year. And this is why. Did anyone see that video of the couple sleeping driving the Tesla while the car drove itself? Or how napping for 20 minutes during the day increases job performance? What most people didn't notice was that the researcher mentioned in that study that it only applies to sleep-deprived people. If you're not sleep-deprived, you don't need a nap. So poor job performance, work-related accidents, motor vehicle accidents, family discord, depression. There's some systemic and metabolic like hypertension, insulin resistance, metabolic syndrome, cardiovascular pulmonary issues, cardiac arrhythmias, myocardial ischemia, pulmonary hypertension, congestive heart failure, neurocognitive dysfunction, stroke. All of those are related to poor sleep. What if your body could heal from almost every chronic disease out there with a nutritious diet and exercise? Sleep is also being biologically needed for our well-being, and it has been ignored for way too long because we talk about nutrition and exercise all the time, but sleep has been left out of that. Chronic diseases like type 2 diabetes, cardiovascular disease, obesity, and depression have all been linked to poor sleep. Am I the only one asking why our doctors are not requesting a sleep study before giving medication for any of these conditions? I'll go further than that. Before these conditions have actually happened, because these conditions are fire. The red alarm was there in childhood, right? Whenever they were just, whenever we saw them mouth breathing, whenever they had allergies, whenever they had tubes placed in their ears. I mean, strep throat over and over. Those are all red flags. But these right here, this is already a fire. Our sleep is disturbed and poor quality many years before these conditions show up. What are we missing as a medical community? I have to show you guys this video. So this mom reached out to me for my functional therapy, but she was seriously worried about his sleep. During the consultation, I spoke to the mom and saw photos of his occlusion. I clearly see that his teeth are lingually inclined. I see the wear facets. I see the narrow and retruded maxilla. But it wasn't until I requested a video of him sleeping that I understood the severity of this case. He's not breathing. No, there's a breath. There goes 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. That is 12 seconds without breathing. Every few seconds. This is difficult to watch, but it's important for us to watch. I don't know how many medical professionals will look at this and not see an emergency. As soon as I saw this video, I told the mom, you need to show this to the pediatrician immediately. The pediatrician, after watching the video, recommended Flonase. I don't know how anybody looking at this does not see a boy being choked all night long. This is not acceptable. We, as healthcare professionals, we need to do different. We need to reach out to our colleagues and collaborate so we can better help these patients. So I got this text from the mom a few days later, or probably a week later. She said, girl, do I have a story for you? We ended up taking him to the ER. So she texted me that video saying, She couldn't sleep anymore. She was just sitting next to her child all night long because she was afraid he was going to die. So she wasn't sleeping. The father wasn't sleeping. And she was like, I feel like I need to take him to the ER. And then one day she did. So she took him to the ER, MSI and ear Friday night. And as his breathing was so intense and scary, they sent us home with a $400 copay, telling us to wait for the ENT visit, which was a few days later. Well, after they were doing his sleep study, which was a few days later, at 5:30 a.m., they woke her up saying that they needed to admit admit the little boy to the hospital because his oxygen was going into the 70s. During COVID, who remembers that people were saying if your oxygen gets to 93, it's bad? This little boy to the 70s. They got a temporary CPAP and are meeting with the ENT about the tonsillectomy. And then she said that he had the best night with that thing. You were the only one who took us seriously. I can't even believe how bad the system is that no one could get him in sooner. He had his tonsils and adenoids out, and he's doing great now. But the next step is expansion and myofunctional therapy. The question is, why did it take so long for someone to listen? And why me? Why dental hygienist? To take this mom seriously. What are some symptoms of poor sleep? ADHD symptoms, impulsivity, hyperactivity, and inability to focus. Academic challenges, difficulty in school, lower IQ, stunted growth and development, dark circles under the eyes, swollen adenoids, tonsils, aggressive behavior, depression, irritability, mouth breathing, daytime drowsiness, difficulty waking up in the morning, difficulty with emotional regulation, chronic chapped lips, chronic allergies, teeth crowding, tongue thrust. How about at nighttime? Symptoms are a little bit different. Mouth breathing, snoring, audible breathing, pauses in breathing, gasping for air, drooling, restless, disturbed sleep, frequent night awakenings, bedwetting, frequent thirst or dry mouth if you have to drink water at night, thumb sucking, nightmares, night terrors, unusual sleeping positions, sleep taking, talking or walking, teeth grinding. This research is, I think, one of the most important research for myofunctional therapy. They did a systematic review and meta-analysis of all the research out there. And it showed that myofunctional therapy to treat obstructive sleep apnea is the current literature demonstrated that myofunctional therapy decreased the apnea-hypopnea index, which is the AHI score that you get whenever you do a sleep study. It reduced in 50% in adults and 62% in children. That's crazy. Lowest oxygen saturation, snoring, and sleepiness outcomes improved in adults. It says that myofunctional therapy could serve as an adjunct to other obstructive sleep apnea treatments. Myofunctional therapy is already an adjunct treatment for sleep apnea in Brazil, where I'm from. So much so that speech pathologists who are myofunctional therapists are allowed to become board certified in sleep that only physicians can do. But no, myofunctional therapists can also do it because they work hand in hand. Every time you need something like that, you need myofunctional therapy to relate it to sleep. This little boy is one of my favorite cases. So what does sleep disorder breathing looks like? He came to me. We did 4 sessions of myofunctional therapy. First of all, slight autism, slight ADHD. He wouldn't sit still. And I see all my patients online. So I looked at the mom. I was like, Mom, it's not going to work. There's no way. He needs to see somebody in person. She goes, Renata, I can't. My schedule is insane right now, and I need to do this virtually. Can we please at least try? And I tell all my parents, I said, you're my co-therapist. You guys can see me once a week, but if you guys are not doing these exercises at home every single day, it's not going to work. So the mom put the work in. As soon as I saw him after 4 sessions, I saw his face and I was like, send me a picture. I see changes. You see changes immediately. So when she sent me this photo, I literally cried. After 4 sessions of myofunctional therapy, he was falling asleep within minutes instead of 1 hour. He was sleeping through the night. which before he was waking all throughout the night, he was no longer wet in the bed. And no more melatonin. He had to take melatonin every night to go to sleep. All of that gone in 4 sessions of myofunctional therapy. What are some signs to look for? So eye shiners, the little redness underneath your eyes. Denny Morgan lines are these little extra folds underneath the eyelid, the lower eye. That means 78% chance of having allergies. And the dark circles. All I did was work on tongue position, breathing through the nose, and oral proprioception. You can also see how the white sclera on underneath his eye improved a little bit. You can see more of his eyeball than you did before. The eyeball is supposed to be kind of like a sun coming up, where it's flat on the bottom and you can see half of the eyeball on the top. So it's supposed to be completely the opposite of the first photo. Let's talk a little bit about sleep stages. We have 4 sleep stages, really. It's 1, 2, 3, 4, and REM. 3 and 4 are considered deep sleep. Sleep studies used to be read the same for children and adults. Most kids were being missed, falling through the cracks, because they had all the symptoms, but the study didn't show anything. So Stanford University came out with a new protocol to read sleep studies in children, and mostly physicians are starting to adopt the new protocol. But at the same time, if a patient stops breathing 30 times in an hour, let me explain what AHI is real quick. AHI is the apnea-hypopnea index. That's the number that's going to give you whenever you do a sleep study. You can go from 0 to who knows what. So there is something that shows, I don't have it here, but mild sleep apnea, it's like 5 to 15, 15 to 30 is moderate, 30 or more is severe. For adults, for children, anything is bad, pretty much. Because children have the ability to hold on to more oxygen than adults can. So their bodies work so much better than ours. So we don't see the same readings in studies. In order for something to be considered an apnea, they need to be able to not breathe or be fully obstructed for at least 10 seconds at a time. So let's say you had 10 seconds of pause in your breathing, like the little boy had 12 seconds, that's one apnea. And then they count how many of those happened. They see the amount of hours that person slept, and then they divide by the apneas. And that's how they come up with AHI. So if somebody stops breathing 30 times in an hour, but they only stop breathing for 9 seconds or less, his AHI score is going to be 0. That's crazy, right? So the AHI is not really what we should be going by. People that are really into this now, they don't look only at the AHI, but a lot of sleep physicians, that's all they look. If the AHI is good, they're like, you're fine. I've had several patients who had sleep studies, and they sent me the sleep study, and the AHI was low, and the ENTs were like, you're fine. And then I look at the arousals, which is the sleep fragmentation. Every time your airway is about to close, your brain wakes up. That's what's happening to these kids and young, fit women. The brain or the airway is about to close, your brain wakes up. The airway is about to close, your brain wakes up. So it doesn't fully obstruct because your body works really well. You're healthier. And every single time that happens, one, it kicks you back to stage 1 sleep. So you stay on that light sleep all night long. So you're exhausted during the day, even though you're in bed for 9 or 10 hours. If you're a child, 10 hours, right? But it's a problem. So you have the symptoms, but the sleep study is not going to show. So it's very important for us to learn what these numbers mean. How long are you supposed to stay in each sleep stage? So there's definitely a gap between insurance and medical conditions. And we all know that very well in the dental world. This is actually a friend's son. She sent me this video. I've been following this little boy since he was born. He had something called laryngomalacia, where it sounded awful as a baby. I mean, he just couldn't breathe. It was awful. And she went to several ENTs and nobody could help. Nobody's, said he'll grow out of it. So then they were in Japan, I think it was, and then they moved, or Korea. They moved back to the States, and then she sent me this video when they moved back. So immediately I got her a referral, and he had tonsils and adenoids out. So again, let's count. And then he's going to stop. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. And then he breathes. And it happens all night long. This video was posted on Instagram. And I had so many people send this video to me. As the mom is laughing because this child is making an interesting sound while we are all looking at a child who's struggling to survive. Look at the extent of what your body will do to help you take the next breath. How do you think this child is feeling the next day? Look at the muscle tension he's going to have and the pain that he's going to have. Do you think he's getting any healing sleep like this? The head back immediately gives you an idea of what's going on. We're all CPR trained over here. What is the first thing we have to do when we start CPR? We move the head back because that will open the airway. So any baby, any child that's sleeping with the head arched back, look at the airway. Look at the tongue. The tongue is not up. Make sure they're nasal breathing. What is the worst about this video is the countless comments of people making fun of this child, accepting this as normal. So here we go. Ready? What do you see right there? He's getting a bump on his nose already. Very narrow bite. Do you see the little space in between his teeth? He probably has a lip tie. Most lip ties come with a tongue tie. His tongue is low. Probably a V-shaped palate. His lower jaw is already too far back. You can start seeing the hyoid bone coming out. There's so many issues already that we can tell. Isn't that insane? I posted this on Instagram some time ago. My child was snoring a little last night. No big deal, right? Well, let's replace snoring with struggling to breathe. My child was struggling to breathe a little last night. Is this different at all? I'm not going to touch much into UARS for lack of time, because of the time. But UARS is upper airway resistance syndrome. It was termed by Stanford's physician Christian Guilleminault in 1993. People with upper airway resistance syndrome have frequent respiratory effort-related arousals. They're called RERAS. It's due to higher pressure in the airways, and it sends a message of choking to your brain. If you suffer this RERAS all night long, your body cannot enter deep or REM sleep. During UARS, there's no complete airway obstruction, like I was telling you guys earlier. There's partial obstruction, where the airway is still open about 30% of the time, and your brain wakes up to be able to take the next breath. These arousals happen several times an hour. So these are people who are moving around a lot at night. They have to get up to pee. They have to drink water. There's always all this movement. A lot of women will wake up at 3 or 4 in the morning. You look at the clock, it's always at the same time. I used to do that all the time. I don't do it anymore. But whenever you wake up around that time, it's whenever you're going into REM sleep. And you don't because you can't breathe. All right, let's talk a little bit about my functional therapy. Any breaks? Anybody good? Ashley, will you let me know if you guys want a break?
I think we're good.
Okay. So orofacial myofunctional disorders are characterized by a dysfunction of the muscle tone, movement, and function when performing breathing, sucking, chewing, swallowing, or speaking. Orofacial muscle dysfunction can interfere with normal growth and development of the orofacial structures. To highlight the importance of muscle function, we talked already about Stephen Hawkins with the ALS. Orofacial myofunctional disorders are characterized by dysfunction in muscle tone, movement, and or function. It's not going. It's also known as orofacial myology or tongue thrust therapy or myotherapy, which myotherapy is a little bit different. Orofacial myology is a therapy modality for dental hygienists and speech pathologists that studies the musculature of the lips, tongue, cheeks, and face, and how their dysfunction can affect breathing, sucking, chewing, swallowing, and speech. I usually tell my patients that it's kind of like physical therapy for your face. Myofunctional therapy consists of therapeutic exercises to strengthen and re-educate facial and tongue muscles. We work by increasing muscle tone and promoting muscle memory. Every patient is different. That's why just following a list of exercises will not benefit every patient. We need to understand patients' limitations, muscle involvement, symptoms, medical history, and address each one independently with an individualized treatment plan. Myotherapy is muscle conditioning. We do this before working on function. When to refer to a myofunctional therapist? When a patient presents with sleep disordered breathing, or it really should be breathing disordered sleep. Because it's the breathing that's disordered, not the sleep. Mouth breathing, if they have enlarged tonsils, adenoids, turbinates. When they need orthodontic surgery, so if the jaws are too far back. If they need tongue reduction surgery or soft palate surgery, if you hear them saying, I just went to the ENT and I need surgery. Oral ties, they need therapy before the release. Oral habits like thumb sucking, lip licking, a tongue thrust. And that's me still. What positively influences craniofacial growth? Breathing through the nose, the light pressure of your tongue on your palate at rest, chewing hard foods, and adequate muscle tone and function. And what do we see more and more? People walking around with their mouths wide open, their tongues low, eating foods that do not require chewing, making the muscles of the face even weaker. Something got to change. What are some signs of a skeletal structure that's hypoplastic, that's not growing? The bags under the eyes are called venous pooling. We have a little suture right here on our maxilla. The infraorbital vein goes through it. If the maxilla is too small, it squeezes that vein and it causes the blood to pool right there. An open mouth posture, articulation problems with speech, lateral jaw movement while talking. Those women, they come into your office and they're moving their jaw forward and sideways to speak, TMJ patients immediately. Because you're moving your jaw every time you move your tongue. The tongue's supposed to move by itself. They're definitely going to have TMJ issues. A gummy smile, facial asymmetry, if one side is different than the other. Chapped lips, forward head posture, shoulders rolled forward, overdeveloped mentalis muscle. Those people that have a bump right here, it's like a circle. So those are some photos for you guys to see. The white sclera under the eyes, you should not be able to see those. Venous pooling, the purple. Eye canting, when the corner of the eyes are lower than the inside corner of the eyes. The outer corner is lower than the inner corner. Tired eyes. You can tell a lot just by looking at somebody's eyes. Open mouth posture, asymmetric smile, lip tension, and the mentalis strain. Forward head posture, shoulders rolled forward, maxillary hypoplasia, so if your maxilla is too far back, retreated mandible. What does a tongue thrust look like? So you're supposed to be able to swallow using the muscles of your tongue only by creating a vacuum seal on the roof of your mouth. This video shows a tongue thrust when someone needs to use the lips and the cheeks to help create the negative pressure to swallow. The lips are needed because the tongue is low and low tone.
Can you swallow for me? There we go. You can swallow again. Very good. Okay, can you open a little?
This is the same patient that was hyperventilating in 10 seconds. Her mother is a pediatric dentist and a friend of mine. And I saw her, this is probably, 4 years ago. And I saw her and I was like, oh my goodness, she really needs myofunctional therapy. And they're super busy. The mom couldn't make time. They tried for a little bit. We actually saw some improvement whenever she did myofunctional therapy. I think we probably did a few, I can't remember, 8 sessions, 12 sessions. But then they stopped and they went to get expansion. Well, the expander that they put in her is called a Herbst appliance. It actually retrudes. It says that it brings the mandible forward, but it doesn't. It protrudes the maxilla even more. Not in a, huge, but it's not good. And what happened, her gummy smile got 10 times worse than this photo. She probably had enlarged tonsils and adenoids. Probably enlarged adenoids that I couldn't see. And they were not addressed. So if you do not address nasal breathing and you're trying to expand, the breathing is always going to win. She was still mouth breathing, so she was still growing incorrectly. Actually, every patient that I've had with the Herbst appliance, the gummy smile got worse. Let's see. These are just some videos of an evaluation of myofunctional therapy. What am I looking for? You guys can hear my volume for some reason. Let me see if it's... Yeah, I'm not sure why my audio is not. Let's see, audio settings. So I'm looking at patients too. Look how much food he has to put in his mouth to be able to chew. I don't see anything on my audio. For me to make sure it's working. But I am looking at the open mouth posture. I'm looking how he's concentrating to really be able to chew. We're checking this kid's tongue ties. And these professionals are asking him to stick their tongue out. That's not how you check for a tongue tie. Have the patient eat. Let's see how that tongue is functioning. These are a few other things that we ask them to do to check on mobility. Can they move the tongue without moving the jaw? This patient is actually a little bit hypermobile. See how his tongue goes up a little bit? So they're supposed to be able to move their jaw without doing that. That's a compensation. Mentalis strain, the mandible comes forward. He has to use his lips to help his tongue move. Side to side, the jaw should not move. What else am I looking for? Looking at the tonsils, make sure they're not enlarged. This little boy had asthma since he was 2 years old. He was 9 when he came to me because he was lip licking. In a week, he was done lip licking. In 3 weeks, he stopped all his allergy medications that he'd been taking since he was 2. In 9 weeks, he went back to his pulmonologist, and the pulmonologist said, you no longer have to take your asthma medication. You don't have asthma anymore. To this day, he's fine. It's been about 3 or 4 years that I've seen him. And this is Zoe, my daughter. Oh, this volume is working.
We're gonna measure Zoe.
She has an Alpha appliance in, which is a light wire functional appliance.
Go from first molar to first molar. So I gotta make sure, open up really big, baby. Gotta make sure I go a little bit higher, so I'm on the gums kind of, but make sure not to hurt the child. Different thing. The way that I read it,
I'm reading the little 0 right there. So that's a 34. Almost a 35. And she's at a 38 now after her expansion. I'm still at a 36, so she makes fun of me. An easy way to do this in the dental office is grabbing a cotton roll. A cotton roll is about 36, 37 millimeters. And just hold the cotton roll between 3 and 14. If it fits, they're good. If it doesn't, they're too narrow. They need expansion. What are some other intraoral signs? Malocclusion, tongue restriction, lip restriction, tongue scalloping, high vaulted palate, Werr facets, tori, exostosis, enlarged tonsils. Those are all some good photos of what we're talking about. All of these people have orofacial muscle dysfunction that needs to be addressed. Look at the maxillary cant. It's completely crooked to one side. And then patient starts chewing on one side because it contacts first. And then you only use the muscles on one side. What happens if you only use the muscles on one side? You're going to be even more asymmetrical. The open bite. See how it's a V-shaped palate? That tongue tie was crazy. This little boy could not roll his R as he was Spanish. And after the tongue tie release, he did. The suction completely crooked. Other signs to look for: very large tonsils. That's a bifid uvula. When you see a uvula that's split in the middle like that, that's a sign of a submucosal cleft. They probably have a cleft on their hard palate, but you can't see it because the mucosa is fine. Very, very narrow. Look at that crossbite on this side. That's called the bubble palate when it goes in like that in the middle. That was a tongue tie. The gummy smile. This is low tone. These are two sisters that came to me. They're twins. Actually, one of them came to me because she was snoring and having difficulty in school, lack of focus, didn't do great in sports, was overweight, all of these issues. Her father is an MD. And as soon as she opened her mouth, I almost fell backwards. I was like, Mom, have you seen those tonsils? Like, those need to come out. There's no myofunctional therapy that I can do here. Because one of the goals of myofunctional therapy is tongue position. You got to suction your tongue to your palate. What happens if this child suctions her tongue? She can't breathe. She won't be able to. So I told the mom, she's like, oh, her father will check when he gets home. She's 10 years old. He hasn't checked this far. But she had her tonsils out. And immediately she's feeling so much better. Her grades in school have improved. The teachers are saying how much better she's doing. She's more confident. She feels better. She's sleeping better. This is called a Friedman score, tongue positioning. So I check this on my patients. There's two different ones. The other one's called Malampati. It's more common than Malampati, but I don't do it anymore. You ask the patient to open and stick their tongue out. And all you're looking for is how much of the airway back there you can actually see. If you can see a lot of the airway, that's a category 1, 2, 3, you can barely see, and a 4 is completely blocked. This is used a lot by anesthesiologists when they're going to intubate a patient. They ask to see. Every time I have surgery, they check and I go, what's my Malampati? And they're like, how do you know that? But it's pretty much to see if it's going to be easy to intubate that person. Well, everybody over here on the 3 and 4 category are a higher risk for sleep apnea. Those are the patients that are going to be hard to take bite wings. Those are the patients that are going to gag, that are going to choke, that are going to have their tongue going everywhere, following you around whenever you're cleaning. They're the ones that are going to be pursing their lips. And these are all ways to protect their airway. There is something right and wrong about these pictures. Can anybody tell me what it is? Ashley, you might know.
Well, we've definitely got that crossbite going, anterior open bite, for sure.
Mm-hmm. Anterior open bite, crossbite over here. Very good.
Mm-hmm.
So why is this one okay? Because we see that tongue. So that's my daughter. And when I saw that, I almost fell backwards. It was in the orthodontist office. They took this photo, and I was like, because immediately you see the tongue and you're like, oh my gosh, tongue thrust, right? But no, that's okay. The tongue plays a crucial role in helping our facial structure grow. So you need the tongue pressure. But what's the difference between these two patients? This patient is a nasal breather because you don't see any openings anywhere. This patient is a mouth breather. The tongue is low. They have to breathe through their mouth. So look at the difference now of the arches. Of course, her arch is small and we did expansion, but his is very, very transverse deficient. And with the open bite, so many more issues when they cannot breathe well. No two frenums are the same. You guys are inside the mouth every single day. Start looking at tongues. Start looking underneath their tongue. The more you look, the easier it's going to be to recognize if somebody has a restriction or not. Even people that see these for years still have a hard time sometimes, but every single one of these tongues right here are restricted. And they're all different. Everyone will compensate differently based on their structure and muscle tone. That is why everybody presents with different symptoms. The proper way to evaluate a frenum is by checking function, tongue position at rest, breathing, chewing, swallowing, elevation, speech. One of the most important things when building our team, whenever you guys start working with other providers, is coming up with a way to classify what we see. Dr. Soroush Daghi and his team at the Breathe Institute came up with this protocol for tongue tie assessment and classification that most people use in the US right now. They're changing a couple of things that they do, but no one should be assessing a tongue tie by asking the patient to stick their tongue out. I'll always ask, open as much as you can. And now you're a statue, nothing else moves. Slowly move your tongue up. That's what I say. Don't touch the roof of your mouth because I want to be able to see the tip of the tongue. Or don't move your jaw. Then I ask if they can suction or if they can click their tongue and ask them to hold. Pretty much we're looking for the maximum opening, and you guys can do that and look at yourselves in the mirror. Open as much as you can comfortably. And slowly move your tongue. Don't move anything else. Make sure your jaw is not closing. Move your tongue. How much of that maximum opening does your tongue cover? Does it cover about 25% of that opening? Does it cover 50%? Does it cover 50 to 80%? Or does it cover 80% or more? But then after that, we're going to look into compensations. The same thing when you're suctioning. But after that, we're going to look into some compensations. This is now how you check for a tongue tie. So the same thing, open all the way and lift your tongue up. Great. It looks like it's 60 or 70%. It's not bad. Well, let's ask the same patient to take away a compensation, which is floor of the mouth elevation. So I'm having him hold the floor of the mouth and I ask him to lift his tongue up again. He can barely do it. So that's his true elevation, because the tongue should move away from the floor of the mouth. They're two different structures. These are some patients that I have had their tongue released. And it's crazy because this is the first visit. After myofunctional therapy only, he got so much improvement. And then this is day 6 post-frenectomy. This is day 13. And it looked like he didn't really get much better. Looks the same shape. All of a sudden, we kept doing stretches, kept doing myofunctional therapy. This is almost a month later. All of a sudden, he goes, whoop. This is a patient, as soon as they are that restricted, I tell them, sorry, this is going to be a 2-step release. You're going to have to get a release once and then probably going to have to go back later. But this is one of my best release provider, Dr. Samira Jafari in Atlanta. She is the best. She's the one that did mine too. But that was only one release and insane. So good. This is to highlight the importance Are you a grade 3, Ashley? Yeah, those are the most common, I think. And the grade 3s are the ones that give a lot of pain for the mom breastfeeding. The importance of orofacial myofunctional therapy before the release. So this is before the release. This is when he first came to see me. And then this is after myofunctional therapy. He had a release. I'm going to show you guys a release. But after myo, before the release, we had reduced facial muscle tension. Look at the muscle, how much more contracting he is, those muscles there. Now he's more relaxed. His lips are more relaxed. He can lift his tongue so much better mobility, much better tone on that tongue. He has more control over it. Increased tongue position awareness. Now he knows where his tongue is supposed to stay all day and all night. And he can breathe so much better through his nose. That's his release. So it was a functional frenuloplasty by Dr. Samira Jafari. Look at how beautiful her stitches are, and there's so many of them. So they're way less likely to reattach when she does that. We did 12 sessions of myofunctional therapy. He actually had expansion done first, then he came to me. Then we did 12 sessions, then he did a release with the CO2 laser, the light scalpel, with the sutures. Then we did more myofunctional therapy, and I just released him like last week, I think. Now, how do we screen these patients in the dental office? This is called the Ferris 6. And it's a simple, super simple way for us to quickly screen a patient and see if they need a referral. So the first thing that you do, are they mouth breathing? Yes or no? Check. Do they have mentalis strain at rest? When somebody's just standing there, are their lips open? And then do they have strain? Check. Third one, we're going to look at tonsil enlargement. You guys saw a couple photos of the tonsils being super swollen. Okay, how much of the airway can you see back there? If it's a grade 1, you can barely see them. Grade 2 is a little bit more. A grade 3, they're 50% covering the airway. And a grade 4, they're pretty much touching like the twin sister. And then you look for the tongue tie. And then you look for dental wear. I talked, I think, earlier about bruxism being an airway issue. Whenever you can't breathe well, your brain goes into stress and your sympathetic mode turns on, and you have to be able to breathe. So a lot of times you bring your lower jaw forward. That pressure and bringing the lower jaw forward, you help your tongue come out of your airway, and then you can take your next breath. So it's the whole thing of clenching and grinding. We're gonna find out why, but grinding, usually airway issue. Narrow palate. They should have a beautiful U-shaped palate. If it's more of a V, or if they have any cross bites in the back, they're too small. And that's the measurement that we do. Actually, that measurement is showing that measurement is incorrect. We don't do this one anymore. We go from here to here. So we measure the palate and all the teeth. I like to see women at about 36 and men about 40 or 43 millimeters. And then you got to build your airway team. It's hard. This is, it works because it's a multidisciplinary approach. I'm not doing myofunctional therapy by itself. It works because I'm working with other professionals and they're addressing what they know best. So if you work with babies, you might need an IBCLC, which is an international board certified lactation consultant. You may need a speech pathologist, ENT, an orthodontist, an allergist. I send my patients to get an allergy panel all the time. If they can't breathe, a lot of times there could be allergies. An airway or a pediatric dentist, a craniosacral therapist. A lot of occupational therapists do this. It's a modality of treatment where it doesn't really look like they're doing anything. They kind of just touch and hold certain areas, and they're feeling for your cerebral spinal fluid movement. And they can kind of move things around, and then you feel better. I don't really know how to explain it, but it's magical. An osteopath, they also do some adjustments. A cranial osteopath is better they do, very hard to find, but they do these cranial adjustments. Remember I said we have all these sutures and these sutures are still malleable. They can slowly adjust those, especially if people had trauma or have constant headaches and stuff. It's very important to see where those are located or asymmetries. A feeding therapist, a physical therapist, occupational therapist, sleep physician. Build your team. How do we evaluate a tongue tie? Oh,
You're gonna open
volume
up
is up.
and stick your tongue out and then in. Say, stick it out and put it back in. Stick it out and put it back in. Put your shoulders back, baby girl. Your chin down. Yes, right there. Straight out.
So the tongue is going low. There you go. She was using her lips and opening and closing her jaw first. Cannot go up and down without moving her lower jaw forward or without closing her mouth a little bit. Then I look at the suction to see how much she can open with the suction. But see, she just brought her jaw to one side. She really needs expansion before release. But that was an interesting case.
You say na na na.
Na na na.
La
La
la la la.
la la. La la la.
So for this one, I'm looking for the tongue mobility. Does the tip of the tongue touch the incisive papilla when he says these things? And you guys can try this and look at yourself in the mirror. La la la, na na na. These things should be done without much jaw movement. For da da da, na or na na na, it's more common. They're gonna move their jaw, or ta 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 and da 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 actually. But you can tell when they're saying that. The first one, his tongue was completely low. I'll play it again.
Say na na na.
Na na na.
See, the jaw was just doing all the work.
La 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 la.
La la la. La la la. La la la. La la la.
But
Ta,
coming
ta,
forward,
ta.
Ta ta ta. Ta ta ta. Ta ta ta. Ta ta ta.
And da da da.
Da da da. Da da da.
so what else do we look for?
Record as I'm going through them. This one does not.
I'm looking at lip ties.
That's the lip tie. Nothing here. She's fine. Lip tie.
I'm not gonna see it any closer than that. It starts.
Eyes. Your kids are so beautiful.
These kids are from Sweden.
Let's see. She does have some floor of the mouth elevation, but she has really good range of motion.
See how much she can stick her tongue out? Nobody would ever say there's a problem there.
Any, oh yeah, the swallowing needs work, but barely any, yeah, it's a short frenum. I can see that little Eiffel Tower down here, but she has great range of motion. Yes, usually they.
So do you release every tongue tie? Sometimes you don't have to. There's plenty of people walking around there fine with a tongue tie. But there's different grades of restriction, and like we're talking about, everybody's going to compensate differently. I think I'm going to skip these. Let's see. Yeah, I think we have time.
1, 2, 3, 4, 5. Lizard.
Oh, this is therapy. I'm doing therapy.
1, 2, 3, 4, 5. That's 5. 1, 2, 3, 4, 5. Lizard. 1, 2, 3, 4, 5. That's 6. Now swallow, suction for 30 seconds. Show me. Good job. One more time.
See how much food he put in his mouth? That's way too much. Skipping a little bit.
Okay.
Food is everywhere. So for this one, I was doing an evaluation for this middle one. But do you see? Look what he's doing to be able to swallow. Look at all the muscles he's using. He's supposed to use his tongue only. Look how difficult it is for this child to eat. How much energy it takes. And it's something easy to break down. Do you think he eats steak? There's no way. It would take him way too much. He'd probably choke, or get because he can't break it down all the way. But it's crazy. Let's see what she's doing. That's also therapy. To be able to swallow using the tongue only.
Good job.
There he goes.
One.
All right, let's talk about some case studies. Any break or any questions before case studies? You guys good?
We're good.
All righty. So this little girl came to me. I didn't think I was going to be able to help her. She would break down and freak out every single session, like bust out crying. She just would get so upset, extremely sensory, very emotional. And we did a sleep study. She came back with sleep apnea. This is just after therapy. After this, so we did therapy for some time. After this, she removed tonsils and adenoids, and then tongue tie and lip tie, and then she had just had expansion. She just got done with expansion. She looks completely different. I need to get an updated photo of her. But look at the difference just with therapy. It's interesting to me. I've been noticing this a lot, where the nose is starting to form a bump. Do you see how her nose was kind of forming that ugly bump? And then all of a sudden, look at that. It's pointy and beautiful. Because the tongue is in the right position, everything now is growing correctly. This little girl, forward head posture, it almost looked like she grew her cheekbones. Look at that. The mandible is in the right position, tongue is in the right position. She's more confident, she's happy. She was the hardest working patient ever. She did her exercises so well. And I noticed that every time I would ask her to do exercises, she had a very hard time processing it. Like it wouldn't go through her brain as well as other people. And I started going like, there's something wrong with this child. I don't know what it is. So I referred her, and they think she has apraxia. Apraxia is when your brain doesn't tell you. You tell your brain and the muscle doesn't do what you're asking it to do. It's usually caused by trauma during birth or something like that, if they fell. So it's interesting the things that we are starting to notice. This girl also has some a disorder. I don't know what it is. But look how far apart her eyes are. There's something. I don't know what it is. And when she talks, it's just she's different. But again, I sent her to a geneticist. Is that what's called? To find out what's going on with her. But this is only after like 4 sessions. Look how she would stand with her arms like that. So much tension. Her smile was completely asymmetrical. How crazy is that? That after only a few sessions, she can stand fine. And beautiful wide smile. Cognitive behavior is better. She, listens better. This is only after 3 sessions. This is probably after 4 or 5 sessions. That's the little boy I talked about already. And she was my most recent one. After 5 sessions. The mom was like, we're noticing so many changes. Myofunctional therapy only. Look at her posture. Insane. This little boy had autism, or has autism. And we did, I don't remember how many sessions of therapy this was, probably around 8. But look at his whole body changing just by working on tongue position and nasal breathing. His facial features, everything is more balanced. Isn't that crazy? His back, it's just everything changes. It's so beautiful what we do. So I always like to say that you can't make a difference without making waves. And some people in the boat won't like it. You guys know what I'm talking about. Whenever you start talking about this stuff, there are so many people in our profession that are going to be like, there's no way. Like, we don't have time for that, you know? But so be it. Rock the boat anyways. It is so important whenever you see the changes that these people are going through. I also run Aries Circle. We do lectures every Thursday night. I interview people from all over the world. And it's all about this that we're doing. We have a membership. We have courses to become a myofunctional therapist. That QR code, if you guys take your phone out, the QR code or a list of our events. So our Thursday night lives, everything is on there. Go ahead and get your QR code. And I can give anybody who would like to become a member of Aries Circle, I can give you guys a discount. You can use the discount code 100 today for $100 off the whole year. And thank you very much for having me. I am Renata Nami, dental hygienist, myofunctional therapist. That's my QR code for my business card. If you guys need to email me, text me is easier to get in touch with me. So that's it. If you guys have any questions, I'm here. We have a little bit of time for questions and answers.
Looks like we do have a question in the chat. Michelle is asking, her daughter is 30 and has a crooked smile. Is it too late to correct this?
No, there are so many different appliances out there that you can use. I have one. It's called the Marpy, but asymmetries will get worse when you get expansion, if it's a skeletal asymmetry. But is her asymmetry only muscle? Is it because one muscle is being used way more than the other? A lot of facial asymmetries could also be due to cranial nerve dysfunction. So was there any trauma, any car accidents, any falls? And it could also be emotional trauma. If something super, big happened in her life, it can affect your muscles, which is crazy. So you got to investigate depending on what it is, we can help. Questions? You guys are welcome to unmute and turn your cameras on if you'd like. You guys are welcome to follow me on Instagram. If you go on Instagram, it's Myo Moves, MYO MOVES. I post a lot of info over there. Here, I'll put it here in the chat box for you guys. I'm curious, how long have y'all been hygienists? Do we have all hygienists in the room?
Hygienists and dentist.
Awesome, we have a dentist. All right, we're going to be bugging you now. 20 years hygiene, awesome. And as soon as I learned all of this, I was like, oh my gosh, I've missed so many patients. So many patients. I mean, you get close to a patient, they start gagging. If you get close to them with a bite wing, that's an airway patient. They fall asleep in a chair, that's an airway patient. Those annoying patients are airway patients. The kids that are touching everything, always have a runny nose, airway patient.
Mm-hmm.
And all you have to do, it's a lot of information. And I haven't even given you guys, half of it. But it's planting seeds. That's all you gotta do. How did you sleep last night? That's it. Simple. Start slow. Where do you start? So I'll put, let's see. Do I have the link? Let me see if I have the link. Okay, right there. The link again to our Facebook group. So we have a group of 2,600 professionals right now on Facebook, and we post stuff there all the time. Research articles, and we're asking questions. Where do we find a professional? Now, as far as training, there are several places out there that offer training. It's tough because I got most of my training from Brazil. I've done several here, but most of my training is from Brazil. And the United States is very outdated. Things that they were doing 20 years ago in Brazil, they're still doing here. But you have to start somewhere. I'm not going to tell you which one is the best because Now I know what everybody teaches, and there are some things that are not accurate, but like I said, you got to start somewhere. So there is the IAOM. The IAOM is the only nonprofit organization that offers a true certification in myofunctional therapy. It's called the COM, Certified Orofacial Myologist. But if you take one of the courses, actually now they just open where you can take any intro course and you can become a member and you can try out for the COM. Before it was a 28 hour course, and it was just, there's no way you can learn all this stuff in 28 hours. Yeah, my first myo class was also through them, but I studied by myself for 2 years. So what I did was just I bought a bunch of books and I started taking courses in universities in Brazil from here. So after 2 years, I'm like, okay, now I'm ready I really need to learn how to treat. And I took the IOM class, and it was like 2 whole days of anatomy. And I was like, I know all of this stuff already. Like, how do I treat? What do I do? And they barely teach you that in 28 hours. There's not enough time. So I was a little lost, and it's very common for everybody who takes their first course to feel overwhelmed, not know exactly where to go and what to do. And we're not business owners. That's another thing. Are you going to work with a dentist? Are you going to work by yourself? So it's just a lot of stuff you got to take into pieces. So my recommendation first is getting one of those books, either the Dental Diet, Breath, or the Oxygen Advantage. Those are great books to start. There's some other ones. There's Breathe, Sleep, and Thrive by Dr. Shreem Lim. There's so many books out there now. But start by reading a book so you have a little bit of knowledge, a little bit more, of course, than you got today. Then start asking around for people that have taken other courses. But the first course you take, it's always going to feel like it's too much. It doesn't matter which one you take. Nobody likes their first course for that reason. One is not enough. That's very important for me to say. As a myofunctional therapist, you're going to have to love to study. We don't stop. We're always learning because this field is so kind of new, right? But it's exploding right now. It's never ending. That's why we do the Airway Circle Lives. Every Thursday, we have a new speaker come on and we're learning new things. So I'm actually not going to mention anybody else. The IAOM is the only one that offers a certification. You can take any other course. But some are a little bit better than others. So that's why we decided to put on a course ourselves. So we put together an advanced course in myofunctional therapy. So I let everybody do their intro courses. And I said, okay, well, after you've been practicing for at least a year, you've taken 2, 3, 4 courses, now you can come take our course. And the way that we do it, it just blows your mind. The way that they do it in Brazil. But you have to have some experience before you see what we're doing, because it's just too much. It's amazing. And then we also have a course on business. How do you open your business? How do you start? How do you do your marketing? How do you do your trademark your name? So we have a lawyer come talk to us, and we have somebody talk about your website and your logo design, and creating your NPI number, all these business things that us hygienists are not used to it. So we just guide you step by step. This is how you do it. This is how you see a patient. We show videos of us seeing patients, doing consultations, myofunctional therapy assessments, therapy sessions, several of them. What do you need for your office? What do you purchase? What should you have? What should you not have? What do you need to gather for your therapy session? What do you need to gather for your consultation? Plus more and more stuff. How do you do referrals? Our business course is insane, and it's all online. How profitable was it? I make way more money than I did as a hygienist. I would never go back. I love hygiene, and I went to get my teeth cleaned today, and I was like, oh, I miss it, but I don't. You can make your own schedule. You can work whenever you want to. It's a little bit different lifestyle. I don't work as many hours seeing patients. You have, of course, a lot of paperwork to do. We have a business to run. It's different. It's a lot more pressure. But per hour, it's a lot more. So it depends. For those people that don't want to work every day, you can work less and make more. and have a better quality of life. I'm all about helping, especially moms. Like if you're a mom and you want to be able to spend more time with your kids, which is awful that I'm saying that because I work a lot. I work until midnight, 1 o'clock because of Aries Circle also. So we have the business course, but we are launching August of 2024. We're launching our first intro course. So finally, I told the girls, okay, everybody's coming to me asking me which first intro course I take. And it's gotten to the point, I used to recommend the ones that I took, but it got to the point that I started seeing what they were teaching. I was like, I can no longer recommend anything. So I need to come up with something myself. So ours is going to launch in August of 2024. So we kind of have something on Aries Circle now that's called Mayo University. And we have the intro course, and then we have the business course that you can take whenever, and then we have the advanced course. With the advanced course, after that, you can join our little group. We have it's called Mayo Meets, and we meet once a month. We go over cases. We're always learning and growing together. We have a WhatsApp group. Yeah, we're always asking questions. If you don't know something about a patient, it's a huge support group for entrepreneurs, entrepreneurial women, and for myofunctional therapy. It's amazing. We learn so much together. But it's one of those places that you just feel comfortable and safe asking questions, because it's scary to come out when you're first new myofunctional therapist and there are so many people in the field that are going to be mean to you. So we decided to create a group where we're nice. Pretty much. So this is my office. My office is above my garage in my house. I have everything set up to see patients here, and I used to see patients here. There was not a problem. Nobody cared that it was above my garage. Everybody was fine. But then I started a second company, and I'm running both companies out of this office. And it just got to be too much. I have boxes everywhere, and I just don't have time to stop. So I'm now 100% virtual. And I see patients all over the world. I have patients in China, Dubai, Japan, Sweden, Lithuania, Australia, Canada, you name it. They're everywhere. But it's fun. It's a fun field. I mean, it's amazing to be a dental hygienist. But as far as quality of life, reducing stress, and being able to do things whenever you want to do it, and then you see how much you're helping people, because you're changing people's lives doing these things. I mean, if you improve their quality of life, they're going to live longer. You know, it's insane. And we all love helping people. If you're a hygienist, you love helping people 100%. So this just gives us an extra feeling of gratitude that I cannot even explain. But I am here. You guys have my contact. If you ever need anything and you want to reach out, it's easy to get in touch with me on social media. I'm on Instagram. I'm on Facebook. You can look for Myo Moves or Aries Circle. But join our Facebook group. You just have to put your info. Got to make sure that it says you're a hygienist, because that group is just for professionals. We don't allow any patients in there. Any other questions you guys may have? So start studying, and then August 2024, you can take your first course with us. It's going to be the best intro course in myofunctional therapy in the United States.
Perfect. Thank you, Renata, so much. Wonderful, wonderful discussion and presentation as always. Love hearing from you.
Thank you.
All right. Do we have any other questions?
All right. If you guys have anything else, just reach out to me. And I'll be happy to help you guys, guide you through it. Yes. Good night. Thank you, Ashley, for having me. I really appreciate it. And I'll send you the recording when I have it uploaded.
Perfect. Thank you so much.
Thank you. Bye.
Good night.